Hi guys, Lizzie Barrett here. I'm the nurse educator out at Nepean Hospital in the intensive care unit. And I'm going to take some time today to talk to you about non-invasive ventilation in the acute setting. So this is by no means a comprehensive talk. It really is a beginner's guide too. So suitable for people who maybe have done non-invasive ventilation in the past but haven't done it for a while, or for those of you who are moving into an intensive care unit or into a respiratory ward environment where you need to apply this therapy and it's not something you've done before. I guess a couple of caveats before we get started. This is a generalized talk. It's not facility specific. So just make sure that you are familiar with your local policies, procedures, and work guidelines, whatever they may be, because there are small differences from facility to facility, and there are differences from machine to machine. So you will need to be familiar with what is common practice where you are. The other thing just to note is that this is very much about non-invasive ventilation in an acute setting. So this is patients who are acutely unwell with an acute respiratory issue. This is not in any way, shape or form meant to be or gives you information on non-invasive ventilation for chronic conditions in chronic patients. So please don't take this information and apply it in that patient setting, because there are some differences in terms of how we apply that therapy, and it's certainly not my field of expertise, though, that chronic patient group. So today we're going to look at acronyms, and like with a lot of topics in the medical world and in subspecialty land, there are a lot of acronyms, and it's really important that we become familiar with them, because use of acronyms leads to miscommunication, and miscommunication leads to incorrect or inappropriate therapies being applied, and that can have really dire consequences for patients. So please, if you're ever unsure about an acronym, you can't remember what CPAP means, you're not sure what PS is, ask someone and clarify. And I guess I also like to say to people when they're learning a topic, try not to use the acronyms. Try to say the actual words, and say them in their full long way, because the words themselves will often tell you what the acronym is. I'd really love for you to be able to understand the concept of positive end expiratory pressure, pressure support, and inspiratory positive airway pressure by the end of this lecture. They're the core pressures that we apply in non-invasive ventilation. And so it's important that we understand those. To be able to describe common patient presentations where non-invasive ventilation may be required. And let's be honest, at the moment, and one of the reasons why I'm doing this lecture is because we're using it a lot in our COVID-19 population. And so that's why it's important that we're good at it and we're familiar with how it's applied. It would be great if you feel reasonably confident in applying these therapies on a patient regardless of machine. And like I said in the intro, there are going to be slight differences from machine to machine, but those core principles remain the same. Yes, you need to learn where the buttons are. Yes, you need to learn how to dial up your oxygen or set your pressures. Yes, you need to know how to troubleshoot alarms and what various alarms mean. But again, the core principles with these therapies are universal across the board. And I guess most importantly, you need to be able to identify clinical signs that the treatment is either working or failing. As nurses, we're the ones at the bedside all of the time. It is up to us to advocate for our patients. If we're seeing something in particular not work, we need to escalate that. And often early escalation is, always early escalation is better than late escalation, because it gives us opportunity to maybe try different therapies before we're getting to a really critical point in the patient's condition. So acronyms and definitions, and I've listed here, most of the acronyms that you would find in the non-invasive ventilation world, and we're going to go through each of these on the subsequent slides. So NIV is non-invasive ventilation, CPAP, continuous positive airway pressure, BiPAP, bi-level positive airway pressure, FiO2 is fraction of inspired oxygen, PEEP is positive end expiratory pressure, EPAP, expiratory positive airway pressure, PS is pressure support, and IPAP is inspiratory positive airway pressure. It gets very wordy, doesn't it? Which is why we love the acronyms. The ones that I've highlighted there in red, so CPAP, PEEP, and EPAP, are all terms that mean the same thing. So yes, they're different words, but they are interchangeable and they all mean a pressure that is felt at the end of expiration. So it's a positive pressure that we're applying at the end of expiration. So NIV, non-invasive ventilation, it is what the words suggest. We are providing ventilation, so that's pressures, either an expiratory pressure plus or minus an inspiratory pressure to the patient non-invasively, so via a face mask. That mask can be an oronasal mask, like the one you see on the left, or a full face mask, like the one that you see on the right. Some of you will have seen or be familiar with a nasal mask, and I'm going to go out on a limb here, and there might be some people who want to contradict me with this, but I'm going to say that in the acute setting, for an acute respiratory failure issue, we do not use nasal masks in the clinical setting. And the reason for that is that we need to provide accurate and consistent pressure levels. That's what we're setting on the non-invasive machine. And when you just have a mask on the patient's nose, every time they open their mouth, all of the gas flow that we're giving just comes out the mouth because it's the path of least resistance, and you actually lose the pressure in the airways that we're trying to deliver. So yes, suitable for chronic conditions, not usually suitable for acute conditions. CPAP stands for continuous positive airway pressure. Now, this is a therapy that can be delivered via a range of different machines and equipment. And I've got some images here of the machines that we use across the Nepean campus. You might have ones that are similar in your facility, or you might have ones that are a little bit different. And they range from quite fancy machines there on the left, right through to machines that are more basic here on the right. But really, when it comes to giving the therapy of CPAP, they all do exactly the same thing. Obviously, the simpler designed ones are easier to use, more, I'm not going to say more intuitive, but there's less things to push, there's less things to look at. So it's easier as someone who's a novice or someone who might not be familiar with that particular machine. It's often easier just to look at and work out, how you set it. With the more complex machines, sometimes you might need you'll often need an orientation or some specific training on those machines. That's not to say that you don't need them on all machines, but the more basic ones are often a bit easier to work out. CPAP is it's a mode of non-invasive ventilation where we are applying a continuous positive airway pressure. So it's a positive pressure that's applied throughout the entire respiratory cycle. So that's both when we inhale and exhale, but where we actually feel it, or where the patient feels it, is when they're breathing out. So they're breathing out against a positive pressure. BiPAP. So BiPAP, and I'm really hoping that I'm just going to move this one down here so that you can see this properly. So BiPAP stands for bi-level positive airway pressure. So this is a mode of non-invasive ventilation where, yes, again, we are applying an expiratory pressure, so a pressure at the end of expiration. But on top of that, we're actually adding a pressure when the patient breathes in. So as the patient breathes in, we're applying a positive pressure, and it makes it easier for the patient to take a bigger breath. So it's bi-level, it's two-level. We have two pressures. So CPAP, which is, the one level. So that's always got an expiratory pressure. Bi-level has an expiratory pressure, and now we're adding in an inspiratory pressure. On most machines that you can do CPAP on, you can also do BiPAP on. So the machinery is much the same. There may be a couple out there on the market that only do CPAP, but they're usually quite unusual in an acute setting. Most of our machines that we would have access to do both. All right, let's talk about oxygen. So we've just talked about pressures. So when we're applying non-invasive ventilation to a patient, depending on what the mode is, so if the mode is CPAP, we need an order for an expiratory pressure. If the mode is BiPAP, so the two levels, we need an order for an expiratory pressure and an inspiratory pressure. In addition, we need to know what kind of oxygen we're going to start this patient on. Now, in reality, in most settings, nurses usually can titrate oxygen. And again, this can be facility dependent or location dependent. So please be familiar with what your local practice is. But usually we can titrate oxygen. In some areas, or I'm going to say in most ward areas, you would never normally titrate the pressures. That would be done either under following a direct order by a medical officer, or that the medical officer would do it themselves. So they would titrate the pressures. In intensive care units and some specialist respiratory wards, the nursing staff may titrate pressures, but again, you need to follow your local facility guidelines or practices in regards to titrating both pressures and oxygen. So oxygen can be expressed as either a fraction or a percentage, and it's easy to convert it from one or the other. And the reason why I've put both of this in here is because some machines will want you to put in a fraction of inspired oxygen. Some machines will want you to put in a percentage of oxygen. Some doctors will order you a fraction of inspired oxygen, and some doctors will order you a percentage of oxygen. So it's really good that we're familiar with both terms. So if it's a fraction, obviously 1 is a whole, so 1 equals 100%. And then you just work backwards from there. And you can see that little table I've got on the left-hand side of the screen that shows you the conversion. So 0.21, which is our fraction, is equal to room air, or 21%. 0.3 is equal to 30%. 0.5, so that's our fraction, 0.5 is equal to 50%. And then 1 is obviously equal to 100% oxygen. On some machines, you won't actually dial up the oxygen delivery on the machine itself. You'll need to get oxygen tubing and attach it to a wall oxygen flow meter. Sometimes that will be a low flow meter or a normal flow meter. Sometimes that will be a high flow meter. Again, it's machine dependent and facility local practice relative. So it just depends what you normally do in your setting. But you need to attach that oxygen tubing to the wall flow meter, dial up however many litres has been ordered. And on some machines, it will convert it to a percentage. So you'll be able to look at the screen on the machine. It will tell you as a percentage how much oxygen is being delivered. On some machines, it doesn't even tell you that. So you don't actually know how much oxygen is being delivered as a percentage. And what you do is you actually titrate the amount of oxygen in litres per minute on your wall flow meter to an end effect. So what I mean by that is the doctors might say to you, okay, we've got this machine, we're going to start them on 6 litres per minute. We don't actually know how much oxygen percentage-wise is being delivered to the patient, but I want you to titrate that wall flow meter to achieve a saturations of 92%. And so you would turn your litres up or down according to whatever your patient's saturations are. So that is oxygen. All right, let's get into these pressures in a little bit more detail. So PEEP, or the end expiratory pressure, is the same as EPAP. So, and often the term that we use is location dependent. And what I mean by that is it's really common in intensive cares for us to talk about PEEP. So we use the word PEEP in the intensive care world. In a respiratory ward setting, it's much more common for people to use the acronym EPAP because often their machines, that's what you need to dial up. So that's the terminology that they're used to. But I just want to reiterate again that these terms are interchangeable. So PEEP and EPAP are exactly the same thing. It makes no difference. Now, it's really important that we understand what PEEP is because it's the pressure that we apply across all modes. So there is no mode of non-invasive ventilation where you don't have it. We always have PEEP. So again, I guess it's a pressure that's applied continuously throughout the respiratory cycle. And I apologize if this is, I'm not going to apologize actually, if this is the first time that you're seeing a graph like this, it might look a little bit complicated, but we're going to go through it really slowly because these graphs, we're going to build on it and it will become useful in trying to understand what the terms mean and what the pressures are. So we've got an XY axis here across the bottom. We have our time. So obviously as time elapses, our pressures change depending on whether we're breathing in or breathing out. So up the side here, we have our airway pressures, and airway pressures are measured in centimetres of water. Now, you can see here, just don't look at the graph for a second and sit here and breathe and think about what is happening pressure-wise inside your lungs and airways as you breathe in and out. So as we breathe in, we breathe in, we breathe in, we breathe in, our lungs expand and we reach the maximum amount of pressure we're going to have inside our lungs. And then we breathe out and we breathe out and we breathe out and we breathe out and we get to the end of exhalation and we reach the lowest pressure that we're going to have in our lungs or our airways. And you can see that here. So the patient breathes in, and the pressures go up. And then the patient breathes out, 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 and the pressure drops down. Patient breathes in, and the pressure goes up, and they breathe out, and the pressure goes down. Now, those pressures inside our lungs are like when we breathe in and out normally are very, like they're just naturally determined. Our bodies breathe in until they need to, and they stop and they breathe out. And those pressures just flow up and down as required. Now, when we apply a positive pressure at the end of expiration, we are telling the airways and the lungs at no point in the respiratory cycle, and in reality, this means at the end of expiration, which is our lowest pressure, at no point do we want the pressure in the airways and the lungs to drop below whatever it is that we've set. So in this case, we've set a PEEP or an EPAP of 5. So it means that when we breathe out, we're going to apply a positive pressure so that the pressure in the airways and lungs does not drop below that 5 centimeters of water. Normally it would. And in fact, we usually have a little bit of a negative deflection. We have a little bit of a negative pressure happening inside of our lungs. But when we're doing positive pressure, we're applying that positive pressure to keep our alveoli nice and open. And we're going to talk about that a bit more in a second. So I'm just going to repeat that in case this is the first time you're hearing about this concept. So a positive end expiratory pressure, we apply a positive pressure at the end of expiration is when we feel it. And in this case, we've set it at 5. And it means when we breathe out, the pressure in our airways and lungs is not going to drop below 5 centimeters of water. Now, that's really important because of the end effect it has on our alveoli. So we've got a really simple diagram here of the lung anatomy. And I guess having a much closer look at these alveoli, or the air sacs, which are the components of our lungs that actually participate in gas exchange. So normally, as we breathe in, air flows into the lungs and all the way down to the alveoli. Oxygen goes through the alveoli into the blood. So around each of these alveoli is a little capillary bed. So oxygen goes out of the alveoli into the blood. CO2 goes from the blood into the alveoli. And then we breathe out. The alveoli collapse down and all of that gas flow and the CO2 is expelled. So we exhale and we breathe that out. So again, let's go back to normal breathing, what's happening with you and me sitting here right now. As we breathe in, imagine these, for those of you who've ever seen those, like the little sack of water balloons, or just imagine each of these alveoli as a balloon. As we breathe in, the balloons blow up, and as we breathe out, they collapse down. And as we breathe in, they blow up, and as we breathe out, they collapse down. The alveoli do exactly the same thing. So we breathe in, alveoli open, breathe out, alveoli close. Breathe in, alveoli open, breathe out, alveoli close. What happens when we apply positive pressure at the end of expiration is it actually helps splint these alveoli open. So they don't stay open like all the way open the whole time, but what happens is we breathe in and they open, and we breathe out and we've got some positive pressure, so they stay splintered open. And that's really advantageous because what it means is that the alveoli can continue to participate in gas exchange for much longer throughout the respiratory cycle because they're not collapsing down. The other big advantage is that it helps us push things like fluid back into the circulation. So when we apply a positive pressure in a condition such as, say, pulmonary edema, so if we give someone CPAP or some PEEP in pulmonary edema, that's how we actually get the fluid from their lungs back into the circulation. We essentially just push it back into the circulation. Now, PEEP is really important because it has a direct correlation. It keeps the alveoli open. The alveoli continue to participate in gas exchange, and essentially that has a direct relationship with oxygenation. So PEEP helps us oxygenate patients. All right, so we've talked about PEEP, we've talked about its role in oxygenation and how it does that. It does that by keeping the alveoli open at the end of expiration. Now, what about an inspiratory pressure? So remember, the inspiratory pressure is only applied during BiPAP. So CPAP is the expiratory pressure. BiPAP is both expiratory and inspiratory. So when we're applying a pressure when we inhale and when we exhale. All right, so IPAP and pressure support are interrelated concepts, and hopefully you've already had a look at that graph and you can start to understand it, but we're going to actually work through a couple of examples because again, much like the oxygen component, what you get written from a medical officer might not be exactly the same as the setting options that you have available on your machine. So it's really important that we understand these individual pressures and how we can, because it's a three-way relationship, we only need two of the pressures to be able to work out the third. And you'll find that in clinical practice. The medical officers will order you two pressures. They'll always order you a PEEP or an EPAP. And then they will order you either a pressure support or an IPAP, and you need to work out the other one if that's something you need to set. All right, so we've got the same graph here. We've got time across the bottom, we've got pressure up the side. We've got our PEEP, and we should all be quite comfortable with that. So the PEEP, we've set it at 5. We've got 5 centimetres of water being applied throughout the entire respiratory cycle, but we feel that or the patient feels that when they breathe out. So they're breathing out, and as they're breathing out, there's a positive pressure coming in to keep that pressure in the airways, to keep those alveoli open. Additionally, when they breathe in, we are providing an inspiratory pressure to help them achieve a bigger breath. So we want them to take a bigger breath. So we're going to give them a positive pressure rather than just letting them do it by themselves and they naturally breathe in as much as they breathe in. We're actually going to give them a positive pressure. So we're going to push air down that tube. So as they breathe in, it's much easier for them to take a nice big breath. So in this case, it looks like, so let's just randomly, if we were to draw a line across that, it looks like that the IPAP has been set at about 12. So in this case, I'm going to say we've got an EPAP of 5, we've got an IPAP. Now the IPAP is the whole pressure from 0 to whatever it's been set at. So that's 12. The pressure support is the difference between the two pressures. So it's your IPAP minus your EPAP. So let's work through a couple of little examples. My doctor's come along and they've said to me, Lizzie, I want this patient on BiPAP. I want a PEEP of 5 and a pressure support of 10. But I have a machine where I have to dial up an EPAP and an IPAP. So how am I going to work that out? Well, I've already got my EPAP because remember, EPAP and PEEP are exactly the same thing. So I'm going to put in my PEEP of 5 or my EPAP of 5. So there's my EPAP of 5. Now I need to work out what my IPAP is going to be because that's the setting I need to put on my machine. The doctor's given me an order of a pressure support of 10. So in this case, I need to add the two together. So I've got a PEEP of 5 and a pressure support of 10, which is going to give me an IPAP of 15. So hopefully that's a pretty simple explanation. I'm really hoping that in your facility, the medical officers will be ordering you in the same terminology that is actually on your machine. So if your machine wants you to dial up a PEEP and a pressure support, they will order you a PEEP and a pressure support. If your machine wants an EPAP and an IPAP, your medical officers will write an EPAP or an IPAP. However, obviously it's unusual times at the moment. We're using machines that we might not be familiar with. We're using machines that have been redeployed from all sorts of areas. So it is important that we understand the differences in the terminology and how we work out these pressures. So let's talk about another example. All right, I've got another one here. All right, so remember our pressure support is our IPAP minus our EPAP or our PEEP. Okay, so now I've been ordered an EPAP and an IPAP. So I've got an EPAP of 8 and an IPAP of 20. So remember, EPAP is the same as PEEP. So I'm going to say in this example, on my machine, I need to set a PEEP and a pressure support. So EPAP and PEEP, same thing. So I can put my PEEP in. That's 8. Now I've got an IPAP of 20. So how am I going to work that out? Well, if you have a look at this graph over here, your pressure support, so if I want to set a pressure support, because that's what's on my machine, I've got to take my IPAP, which my order is for 20. I need to minus my EPAP, which is 8, and that's going to leave me with a pressure support of 12. So I'm going to set a pressure support of 12. And that 8 and 12 together are going to give me my total inspiratory pressure, which is 20. Hopefully that's nice and clear. All right, so, and I alluded to this, I guess, a couple of minutes ago, but why do we want to add in either an inspiratory pressure or pressure support? Why do we want to add in that extra level of support when a patient breathes in? It's because it helps them take a bigger breath. Now, bear with me. If you've not done ventilation before, this might be starting to get a little bit of a brain overload, but it is important that we understand this. So each breath we take is measured in mils, and it's referred to as our tidal volume. So as I'm sitting here talking to you and taking a breath in and out, every time I take a breath in, I'm inhaling a certain amount of mils of air. So as I'm sitting here, I might be inhaling 450 mils or something like that. The amount of breaths we take over a minute is our respiratory rate, and all of us should be quite familiar with that. Now, our tidal volume, so the amount of mils we're taking each breath, times our respiratory rate equals what we call our minute ventilation. And our minute ventilation is measured in litres. So I'm going to give you a really simple example. So if I'm sitting here and I'm taking 500 mils each breath, and I'm breathing 10 breaths a minute, and I know that that's not realistic, but let's, for the sake of easy maths. So I've got 500 times 10, which is 5,000. So that is going to give me a minute ventilation of 5,000 mils or 5 litres. Now, if we have a think about a patient who has a respiratory distress, they not only have issues with oxygenation, they can have issues with CO2. So by adding in an inspiratory pressure and helping them take a bigger breath, we actually increase their minute ventilation. Minute ventilation has a direct relationship with CO2. So PEEP, so the positive end expiratory pressure that we apply during CPAP, has a direct correlation with oxygenation. So if we want to only improve someone's oxygenation, we'd probably give them a go on CPAP to start with. If someone had an issue with both their oxygenation and their CO2, which is often the case, we want to give them not only an expiratory pressure, but we want to give them an inspiratory pressure as well, in the hope that we can increase their tidal volume, therefore increase their minute ventilation to actually exhale more CO2. And that's reason number one. Reason number two is it can help us decrease work of breathing. So again, I've used a kind of an extreme example just to give you one, to make the maths easy, but to give you an example. So if you think about a patient who comes in, they've got a respiratory rate of 50, and because they're breathing so fast and so hard, they're taking these tiny little tidal volumes. So they're not moving much air because they're breathing so fast. So each breath they take is only very small. They're not opening up the bases of their lungs. So it's only 100 mils. So 50, their respiratory rate, times their 100 mil tidal volume gives you a minute ventilation of 5 litres. All right, so let's put them on some non-invasive ventilation. Let's put them on BiPAP, add in an inspiratory pressure where suddenly we're helping them take a bigger tidal volume because we're making it easier for them to breathe in. So I'm going to switch that conversion around. So basic maths, we've got a time, so now I'm going to divide it by. So I've got a minute ventilation of 5 litres, which is what that person's body is trying to achieve. So clearly they're breathing so fast for a whole range of reasons, but one of the reasons is that the body is trying to maintain an adequate minute ventilation. So I've got my 5 litres in my minute ventilation. And now, because I've added in IPAP, I've actually increased their tidal volume. So the mils they're taking each breath to 350, which for most adults is still very, very small. I wouldn't say very, very small, but it's quite small, but it's still much better than 100 mils. So now we've increased their tidal volume a little bit, and suddenly to get the same minute ventilation, we've decreased our respiratory rate to 14 or 15 breaths per minute. So now you don't see this every time that you put it on, but it can absolutely help you decrease the work of breathing. If someone who's working so hard to breathe and breathing so hard and so fast, it is exhausting and it is tiring within itself. And obviously these are very sick patients. So there's lots of issues. And the reason for their exhaustion is multifactorial. But the effort of breathing is often one of the components. And if we can reduce that work of breathing while we try and provide adequate oxygenation and we catch them in time, it's often enough to avoid some of the more serious consequences or heading down a track of needing to go to intensive care and needing invasive ventilation. All right, so some indications and baseline criteria. So indications, pulmonary edema we've talked about. So if someone has acute pulmonary edema, it's normally CPAP that we're putting them on. We just want that end expiratory pressure to push all that fluid back into the circulation. CPAP can be very useful in asthma. Both CPAP, usually CPAP, but both CPAP and BiPAP are used when we have a patient who has an underlying respiratory disease, whether that's COPD, fibrosis, asthma, and now they have an acute exacerbation of that illness. So they might have a chest infection on top of that. They might have a pneumonia, whatever it may be. Acute respiratory failure, and this is the big one for us at the moment, so COVID. So we have an infection component with the virus. We have inflammation, so that's what's happening with our COVID pneumonitis patients. They have these big inflamed fluid-filled lungs. But you can also get acute respiratory failure from a range of other diseases, drugs or treatments, and both CPAP and BiPAP are indicated in that. And we use it often as a weaning strategy from invasive ventilation. Someone's been on a ventilator with a tube down their throat for a period of time. We've woken them up. We want to get that plastic breathing tube out, and we take it out and we pop them on the mask instead while they're still recovering from their respiratory illness or their respiratory failure. There are some baseline criteria that patients need to meet to be suitable for non-invasive ventilation. So with everything, there are people who are unsuitable for this treatment. Now, again, things in healthcare, sometimes we really want them to be black and white and they're often not. There are lots of grey areas, and that's because we need to consider the individual risk-benefit ratio for that individual patient circumstance. So whilst this is, yes, baseline criteria, there are going to be times that you apply non-invasive ventilation even though they don't actually necessarily meet all of these criteria. But by and large, they are the exceptions, not the rules. And by and large, you want these patients to have these things. So they need to have capacity to protect their airway. So if a patient is copiously vomiting, they're obviously not going to be suitable to strap a hard plastic mask on their face. They need to have an adequate level of consciousness. They need to have a level of compliance with the interface. And I hate that word compliance when we're talking about patients. You know, the people that we're dealing with profoundly unwell, they're potentially hypoxic, they're not thinking clearly, they've got high levels of stress, they're at their most vulnerable, and here we are doing all sorts of things to them. They, of course, they may have questions, they may not understand. So there's a whole range of factors that that go into that notion of compliance. However, I guess in this context, it means if you have a patient who's developmentally delayed, if you have a patient who's profoundly claustrophobic, if you have a patient who has maybe some mild dementia, they might not actually have the skills or the ability to tolerate the mask being put on their face because, one, of the level of understanding, or two, in the case of claustrophobia, it's actually going to exacerbate their symptoms and they just can't tolerate it. So the patients that we put non-invasive on need to be able to, maybe not happily, but need to engage with us in a way where we can talk them through the therapy. We can apply a hard plastic mask to their face, and we can talk them through particularly the initiation of that therapy. The patient needs to have capacity to manage their own secretions. So either if they've got copious amounts of secretions, they need to be able to get that up into their mouth and then swallow. And they need to have a strong cough. So if a patient doesn't have a strong enough cough to actually get secretions up, remember, these patients have respiratory failure, they've got crap lungs, they've got all sorts of gunk down in there. We actually need to be able to get that gunk up. If they've got a poor cough, then non-invasive ventilation is not necessarily the right treatment for them. Capacity for breaks, and this is probably one of my biggest bugbears around non-invasive ventilation. It is not okay to put someone on CPAP or BiPAP via an oronasal mask and just leave them for hours and hours and hours or days and days without a break. So patients need to be able to come off to eat and drink. And even if we're giving nasogastric feeds and IV fluids, they need a break for pressure injury relief. So pressure relief, I should say, because these devices are hard. They don't move. They stay in the same place. We need to give the skin a break. But we also need to provide oral care. It's an essential care that we do for our patients, and it's a necessary care. It has its own consequences of not doing it, and it's important that we do that. Absolutely, for the first, I'm going to say, couple of hours, even first 2 to 3 hours, yes, the patient needs to go on that therapy and not take a break, because we're trying to get it established. We're trying to get those alveoli nice and open. We're trying to get oxygenation improved, and that therapy needs time to work. But after that, they should be able to have reasonably regular breaks. It might be every couple of hours they come off for 10 minutes just to have a drink of water. We clean out their mouth. Their skin have a break. We might put a protective dressing on, and then they would go back on. Obviously, when they're coming off for a break, we need to provide an alternate oxygen source, and often that will be high flow nasal prongs, but that's going to be dependent on where you are and your access to equipment. But that's a really important one. Every now and then I do see, excuse me, I do see a patient get put on non-invasive ventilation, and then when we take it off, they're so unwell that they just acutely desaturate, increase their work of breathing within like 20 seconds that you take the therapy off. If that's still happening after, say, the first half a day, like say 12 hours or so, we really need to be thinking, are we winning here? Does this patient need a higher level of support? If they're on CPAP, do they need more PEEP? Do we need to switch them over to BiPAP? Do we need to refer them for invasive ventilation? Because clearly their condition is not improving. All right, a patient can't have facial hair. We need to create a good seal around the edge of the mask. There's such high gas flow being provided to the patient with all of these pressures that we're giving. We need a nice seal so that gas flow doesn't escape out the side of the mask. We want it to go into the lungs, not just into the room air. And we need to have a reasonably normal facial structure. And again, I hate that word normal because we all come in different shapes and sizes. But by that, I mean, we just want a normal bony structure that we can actually apply a mask to. So if someone's had a big bony resection of, say, the bridge of their nose, a jawline, that can really impact on your ability to pop the mask on and get a good seal. The other thing to be aware of is that totally lost my train of thought just for a second there. Dentures. So with our patients who have dentures, if they're a full set of dentures and they're well fitting, pop them in. Because they actually give structure, particularly to the lower jaw. And some of you who are used to looking after patients with dentures will notice you take the dentures out and their whole bottom half of their face collapses in. And it can be really difficult to get an adequate seal at the bottom of the mask if you don't have dentures. Obviously, if the dentures don't fit well, don't put them in. They can become more of a risk. And I have seen dentures, like with all of the gas flow, be pushed to the back of someone's airway. So if you've got a patient who's had, say, some significant weight loss over the last few months and their dentures are now too big for them. All right, so application of therapy. So you need to gather your equipment. You need to get your machine, your circuit, something to humidify your circuit. And there was a talk earlier by Anwar-san around the importance of humidification. We're giving big flows of cold medical gas. We have to humidify our circuits, whether that's with a warm heated water bath, so active humidification, or whether that's passively with a HME. You need to get an appropriate size mask. And I'll just clarify here, mask and interface are interchangeable terms. So some people call it an interface, some people call it a mask. And most masks will have some kind of measuring device on it, and any protective dressing you're going to apply. You don't have to routinely apply protective dressing unless that's what your LHD likes you to do, but it's down to an individual physical assessment. What's your patient's skin like? Do they have any pre-existing wounds that you need to cover? Have they recently had some BCCs removed that we need to protect? Do they have very fragile skin? So having a look at that. We want to confirm our order. And again, if we are doing CPAP, we need a PEEP or an EPAP or a CPAP order. And that pressure, so that's the expiratory pressure, positive end expiratory pressure. And that pressure should be no less than 5. So 5 would be a minimum setting for an acute issue. Generally speaking, in a ward environment, you would be happy to go up to, say, 10 or 12 centimetres of water of PEEP in a ward environment. Yes, we can give more PEEP than that, but above 10 to 12 centimetres of water would be considered quite high levels of PEEP. And PEEP itself has consequences for hemodynamics. So it can affect blood pressure. And we just need to be mindful that maybe the patient is needing a higher level of observation or support, and they're better suited to be cared for either in a specialist respiratory ward, a specialist respiratory closed observation bed, or an intensive care unit, or somewhere like that. If we're doing BiPAP, we want to add in a pressure support or an IPAP. So we just need one of those ordered so we can work out the other one. And again, so with a pressure support, so that's, remember, the pressure support is the difference between your IPAP and your EPAP, a minimum of 5. So you want a difference between your maximum pressure and your minimum pressure that you're setting of 5. So less pressure support than that really has a null effect. You don't really see much change in a patient's tidal volume, and that's why we want to make sure we've got a minimum of 5. In terms of an inspiratory pressure, so that's our highest pressure we reach. We don't really want to go above about 28. So once again, there are times where we do go above that. So I just want to reiterate again, this is all quite generic. There are going to be times that you do go above that, but again, probably not in a ward-based setting. So you're more likely to be going higher than that if you've got a patient in an intensive care unit where I guess the monitoring and the observation is closer. And the reason being is because when we're getting to pressures that high, we start running the risk of actually causing damage to the lungs. So we can't just keep blowing up the lungs more and more and more and more and more. It is going to cause damage and issues. It is very uncomfortable for the patients, and it can cause hemodynamic effects. And again, our FiO2, so between about 30 and 50% would be a normal for a ward-based setting. Obviously, we can go up to 100%, but again, it would be around the suitability of individual patients in terms of their location and where they're most safely cared for and looked after when they're on those higher levels of oxygen. All right, so you've got your settings, you confirmed your order. You need to explain the therapy to the patient, provide reassurance, and stay at the bedside at least for the first little while that therapy started. For some patients, that's only going to be 5 or 10 breaths. For other patients, that might be 15 or 20 minutes. Different patients require different levels of support and reassurance. You want to attach the circuit to the machine, plus with your humidification, you want to connect your mask to the end of the circuit. You want to program your machine and you want to start it. When you're actually applying the therapy to the patient, you want to push the mask onto the patient's face, but not too hard. So you don't want the hard plastic on the patient's face. Yes, we need to apply firm pressure because we want an adequate seal. We don't want the gas flow leaking out of the side of the mask, but we don't want to be creating pain, and we want to try and reduce the incidence of pressure-related injuries. On my personal practice, this is not set in stone, but I generally hold the mask with my face until the patient is settled. So again, for some patients, that's 5 or 10 breaths. For some patients, that's 5 or 10 minutes. And I've found over my years of clinical practice that this actually just gives the patients a sense of comfort and confidence that if it's too much, they can just pull your hand away straight away and the mask will come off. It takes a little while for the patient to get used to the feeling of all of this air blowing in their face and to start working with the machine. And once they're there, that's great. You can pop their head straps on and fasten them and tighten them and assess for leaks. But if you do that too early, I've just found that the patients will, they just struggle a little bit more to settle because suddenly they've lost this ability to control whether it's on or off. And it increases their anxiety level, and it increases their feeling of claustrophobia. So just, I guess, like physically holding it on for the first little while until the patient settles is a good tip for helping it be successful. Once you've got the head strap on, you want to assess for leaks. Now, different machines will cope with leaks differently. Some have really good leak compensation, some don't. Some leaks you can fix. So sometimes it's a mask size issue. You've got the wrong mask size. Sometimes you've got too much facial hair. Some leaks we can't do anything about. So if the patient's got a big Salem sump nasogastric and it's coming out the side of the mask, there's not much we can do about that. We just have to try and position it. And sometimes you'll find, out the side it works better than down here. Like it can kind of go into a bit of a skin fold on the side, or it works better coming down. You just need to have a bit of a fiddle to see what works best for your machine in terms of minimizing the amount of leak that you have. I just want to take a moment to just say word of warning about circuits. So 2-limb circuits versus 1-limb circuits. So again, this is going to be different across all facilities and from ward to ward and unit to unit. So some people will have access to 2-limb circuits and some people will have access to only 1-limb circuits. A 2-limb circuit, so what's the difference? A 2-limb circuit has a limb, and when I say a limb, I'm referring to literally these plastic tubing pieces. A 2-limb circuit has a limb, that one of which is for inspiration, so gas flow and oxygen comes up and is inhaled through the mask to the patient. Gas flow is delivered to the patient with oxygen. When they breathe out, the gas flow with the expired CO2 comes down this expiratory limb. And I know that this is an inspiratory limb because it's got a heater wire in it. So we've obviously got humidification somewhere further down the track. And this heater wire up here is measuring the temperature of the inspired gas flow because we don't want it too hot, we don't want it too cold. So inspired air goes in, expired air comes out, and this is a completely sealed circuit. With a 1-limb circuit, and again, I can tell that this is an inspiratory limb, which is all you have on a 1-limb circuit, but I can tell because it's got the heater wire there, so we must have humidification further down here, and we're measuring the temperature of the air we're delivering. So we've got gas flow and oxygen that coming up this piece of tubing and being delivered to the patient. But when the patient breathes out with all that CO2, there's no limb to take it away. So what that means is that somewhere in this mask or this piece of plastic immediately adjacent to the mask, there must be a vent or a hole where that expired air and CO2 can escape. If we don't have a hole, if it's closed and we don't have a hole or a vent, all that gas flow and CO2 that this man breathes out is going to stay in the mask. He's going to rebreathe that every time he breathes in, and he will rapidly become unconscious. So if you have a 1-limb circuit, you have to have a way that air and CO2, gas flow and CO2 can escape, can passively escape this circuit. So it cannot be a sealed circuit. Now, in COVID times, some units have a little filter that go on the exhalation opening, because obviously as that gas flow comes out and the air is expired, it comes out into the room air. So some units do use a filter on that. There are pros and cons to using a filter, and you need to be guided by whatever your local practice is. If you're in full PPE, it's not a requirement, but some places do it. So assessing response. A good respiratory assessment is essential. So looking at your respiratory rate, your saturations, which are the obvious things, your overall work of breathing. Is the patient exhausted? Are they using accessory muscles? Are they sitting bolt upright in the bed or tripoding, what we call tripoding? So leaning on their arms, trying to physically get air into their chest, or are they lying semi-recumbent in bed? Agitation and anxiety level. And I'm just going to, the word anxiety. So it's just really important to remember that being anxious is not a normal state for most people. Yes, there are people who do suffer from anxiety, but they know that and they will tell you, I normally suffer from anxiety. But for most people, that's not a normal state. And the feeling of anxiousness can be a really good sign for us that something is not right, particularly when it comes to respiratory issues. Breathing is such a fundamental thing for us as humans. We have to breathe. We have to get oxygen in. We have to get CO2 out. And so when there's a problem with breathing, it I guess induces this feeling of, discomfort and panic and anxiety. So that's why I say never discount if someone looks anxious or is telling you that they feel anxious, and that's not something to discount. You need to take that into consideration in your physical assessment. It's the same as agitation. Patients who can't breathe get agitated. It's a panicky feeling. They can't get enough air in, they can't get air out, and it kind of really triggers that fight or flight response in us, right? So don't disregard those signs and symptoms. So blood pressure high or low, and I say that in terms of its relativity to the patient. So they don't need to meet Met-Call criteria, but if there's someone who normally has a systolic of 160 and now they have a systolic of 120, that's worth noting. So I guess just remember back to earlier in the presentation, PEEP has consequences on hemodynamics. High pressures have consequences on hemodynamics. It's not something we should ignore. ABG results, we don't always have them, but they can be helpful. But again, it's often first line. We need to go off clinical assessment. We shouldn't be waiting for ABG results to necessarily determine response, particularly in our COVID patients. Their numbers often look dreadful. We really want to see how are they going from the end of the bed? How's their work of breathing? How are they feeling within themselves? I've listed a couple of resources here for you. So the ACI have a really comprehensive NIV guide. It's worth looking at. Life in the Fast Lane, it's more medical, but again, it's quite succinct and has its own list of resources there. And there's a YouTube video that I actually found through Life in the Fast Lane that talks about non-invasive positive pressure ventilation, that if you want kind of a different person talking about it, or a different way of it being described, it's a little bit more medical, but also worth a look. That presentation is worth a look. So I want to say thank you for taking the time to watch this presentation. I really hope it's useful for you. Certainly I think this is number 4 or 5 in a series of 7 presentations. So if you're watching them consecutively, good on you for hanging out this far. If not, I hope this has been of benefit to you. Stay safe, everyone. Stay well. I'll see you soon.